Welcome to the Next Step in Care learning series. This video is designed to provide healthcare and social service providers with ideas and guidance on ways to work together with family caregivers.
And situation is really family preparedness, helping families to understand what's happening, what might happen, and so there's no surprises. And that, when the crisis arises, they're prepared and they have a plan. And it's not just a call at 3 o'clock in the morning to say, there's a change in condition, we're going to send your mother back to the hospital because she has a fever. And then, so the options for Mrs. K that were outlined to the daughter were several different scenarios, okay? The first being that now that she could take oral intake, that she would return to the nursing home where she was very comfortable and had a good support network, continue the oral feeding despite the aspiration risk, continue all the other supportive measures, and await the neurologic outcome. That being said, that the daughter as well had said that if there wasn't going to be good neurologic recovery, or if her condition deteriorated, or if the goal became not to re-hospitalize her, that then she would be referred to hospice. She didn't want hospice when she left the hospital. She wanted to go, with the first plan. But that provision was there and was going to be communicated to the nursing home. The second scenario was that if her oral intake became inadequate during this trial of hand feeding, during this period to see about neurologic recovery, then she could always go and have a peg placed as an outpatient. And that the daughter understood as well that if a feeding tube was placed, that it could be on a temporary basis. It wasn't a permanent situation. She could change that at any time. And lastly, to return to the hospital if any acute issues arose, and that there was a high likelihood of that given how frail and at risk she was for infections. And then opinions is really, many times I think working with families, and these are so difficult in terms of decisions, families will often say, well, if this is your mother, what would you do? If this was your father, what would you do? And rather than speak, to that issue in that way, really to provide your medical recommendation. And I think young doctors, nurses, they really feel very hesitant when asked to give their opinion, although they have one, and to give it based upon the person's clinical situation and the data as you know it, and what the likely outcome would be. That's what people are looking for. And your rationales for those decisions. And then, to use impartial language. Not sometimes do you want us to do everything, and we say a lot of things that kind of have values behind them. So to kind of keep it to the, the opinions based upon knowledge and data. And then the documentation of all of this. If you think about Mrs. K, documentation can be an afterthought. And the patient leaving the hospital and coming out to you in the nursing home, the notes can say, meeting with family, daughter rejected or refused peg, returning to the nursing home, and that can be the end of the note. What needs to be is much more detail about that. The who, why, where, how, and why, and to convey in your notes really this kind of information. What was discussed? What are the possibilities? What are the options that were presented? What's the plan now? And what the plan may become if Mrs. K's condition doesn't improve. And it's an ongoing conversation then at the nursing home and for the caregivers who then take over the care. And lastly, it's essential for the patient's safety and for the continuity of care and for a smooth transition to make sure that these very important things are communicated. And within the hospital now, there's much more emphasis on the importance of this, the importance of the phone call, the importance of the documentation, because this is the education of family members and patients so that they're empowered and they know what to expect, because many times it's not a surprise to us, but it is to a family member because they're ill prepared for what's likely to happen. And the worst time then to be having those discussions is again when the crisis is before someone. The other challenge here is once the goals are clear, and in the case of, say, Mrs. K or another patient where the goals become that of comfort, the plan may be clear when they're in the hospital, but how in a transition from the hospital can you ensure that that plan can be supported and that the expert care that a patient and family needs will be there for them? And I think that's something that the initiative here that's going on is so critically important, because we can't work in these silos, and also systems don't always lend themselves to this kind of transition. So that some of the issues, as I talked with colleagues as well and experience and hear from families, is the challenges of the timeliness of hospice enrollment in nursing homes. So the plan and the goals can be very clear, but when the person leaves, there's no assurance that hospice care is going to be there, or when it will be there. Maybe a few weeks down the road because of procedures or insurance, or the same is true of someone being in a long-term care facility and their care is being covered by their insurance and there's no ability to add hospice onto their care plan. And in that case, sometimes it becomes a comfort care plan as opposed to the expertise of a hospice. And what does a comfort care plan really mean? Who's providing it? What's the skill set? And it's very variable. So knowing about what the program is, who's there, their skill set, that's also something that I think is part of education as well to patients and families, so that they know what to expect and can ask those critical questions before they go to another setting of care. And I think this came up many times, is about the rehab. Rehab becomes the plan when there is no other plan. Sometimes when someone's in need of care and they don't kind of fit within a particular place in the system, it's rehab by default. So I see a lot of heads nodding, and I think we all have faced these challenges.